Welcome everyone. This is highly I, exciting and interesting sessions. Uh, we have with us Dr. Karthik Adapa, who is the Special Secretary of Department of Health and Family Welfare, Government of Punjab. Welcome, Dr. Karthik. Thank you for joining. Uh, Welcome, Dr. Shafqat Khan, who is the Additional Mission Director of Ayushman Bharat Digital Health Mission and Nodal Officer of AI and Ease of Doing Business, UT of Jammu and Kashmir. Thank you for joining. And Dr. Ismaeel, thanks for joining in here. So let me start by speaking to Dr. Shafqat Khan, who is the Additional Mission Director at Jammu and Kashmir. Uh, if you can talk about what is the some of the innovative work which is happening in healthcare IT adoption in the health department in your state, and how it is impacting and changing lives.
Thank you, Dr. Gupta, for inviting us on this very great summit and with this very august gathering and esteemed audience uh, who are specialists in this field of healthcare. Uh, Briefly summarizing what JNK has achieved over, say, the past 1 decade or so, uh, let me put it in the knowledge of this esteemed audience that we have, been able to lower our infant mortality rate from somewhere from 33 to 16. We had a huge uh, jump. We jumped down from rank 33 to 16 in just period of 4 to 5 years. In 2018 census, our IMR had a 10-digit drop, and which has globally not been documented ever. It means that the healthcare system infrastructure which we had was, dovetailed to the needs of the people in such a way, because infra we created over the past many years. Creation, in my understanding, is not a very big challenge. It is the challenge is to uh, dovetail the infrastructure, organize it in a manner that the end recipient, that is the citizen or the patient, has good access to healthcare, smooth access to healthcare, organized access to healthcare. For example, as you know, our tertiary care hospitals all across the country are very overburdened. Our primary healthcare system needs to strengthen. Our district hospitals need to strengthen. Our primary health center needs to strengthen. Our health and wellness centers and the sub centers need to be strengthened. We all are, aware of this fact that we still need to do more in that field. But JNK per se has been able to, operationalize 9 medical colleges, 260 DNB seats. We have doubled the PG number of PG seats in just a span of 5 years. It has happened. 9 medical colleges, and we are heading towards having a medical college per district in JNK. So, having a medical college is on one side an achievement. The bigger achievement is that we are producing a pool of human resource, specialized human resource, which will be there at a district level. The district hospital is now associated hospital of the medical college. We had specialists. We have now super specialists at the district level. Trust me when I'm saying this, we are elated to see that at the district level in J&K, right now, orthoscopic surgeries, laparoscopic surgeries, neurosurgeries are being conducted. For having said that, I want to inform you that we have rolled out the Ayushman Bharat digital mission in J&K. It has been a year, and the journey has been so brisk that as you know, the Abha generation, the Ayushman Bharat health account, it's a unique ID which every citizen of India will have to have. In due course of time, our entire health record, the repository will be in the Abha account. The Abha account will become the key account for all the transactions, health transactions you're going to be making at any given point in time or any health care institution. We have 1.25 crores. We have already achieved 70 lakh Abha accounts. We have mapped 100% public health institutions under the HFR, the Hospital Facility Registry. Our 72% of doctors in the public health sector are registered on the Hospital Professional Registry. The eSahaj software we are using is already installed in 578 institutions. We have more to go. We want to achieve higher limits. We want that our entire process of digitization reaches to a level of artificial intelligence and end up in the ease of doing business, ease of patient care. The patient, used to stand in the queues. You must be aware there is a scan and share facility which we have launched under the Ayushman Bharat digital mission in J&K as well. As of today, 43 institutions are covered in just a span of 1.5 months. We are generating almost 1,20,000 tokens we have generated in just 1.5 months. And we have reached the third slot overall across the country. So reaching the third spot itself tells you that J&K is robustly pursuing a very great healthcare policy. We have the universal healthcare insurance, which is unique in the entire country. J&K has the Ayushman Bharat universal healthcare, which no other state or UT has. Our union territory has everybody, all citizens, irrespective of age, uh, profile, or history of disease, is insured for a sum, a family is insured for a sum of 5 lakh rupees. And we have such success stories. We have such great stories to tell you when we have, been able to lessen the miseries of people who used to otherwise spend money out of pocket. The perspective should be basically from the patient's perspective. We should see the problem from the patient's eyes. I think uh, digitizing things will ease up the burden on the patient, his journey into the hospital, his way of keeping his records, the way of getting out of those long queues he has to suffer from, and ease of delivering healthcare for the doctor and the paramedics and others. With that, I would continue speaking about J&K later in the session as well.
It is interesting and exciting to note that these developments are happening in the state, which is very, very heartening. Increase in the number of medical colleges, increase in the registrations in the Ayushman Bharat digital mission. These registrations are happening so that we can digitize all our patient records in the public health itself is a big, big development, I think. And let me request Dr. Adapa, who is a special secretary at Department of Health and Family Welfare, Government of Punjab. If you can highlight some of the initiatives and especially related to digital, which are happening in your state and how it is like impacting people.
Thank you, Dr. Gupta. It's an absolute pleasure to be here talking to this audience. I'm not very conversant with talking to industry. I'm more of a researcher and then work very closely with the government. So it's going to be jumping into the fire to learn and communicate some of those interesting digital health initiatives because I am by training a health informatician. I'm an MD in general medicine from AIMS, an administrator, an IS officer, but I'm also a researcher who work at Yale and at UNC School of Medicine and School of Data Science. So I'm essentially somebody who's moved from medical to from medicine to health technology. So I design and develop more of AI and machine learning in radiation oncology. That's where my specialization is. But talking more specifically about the initiatives that we've taken in the state of Punjab, I wanted to kind of highlight three revelations, three outstanding examples. Now, before I go ahead, I also want to share that a complete disclaimer. I don't own or I don't take any claim for this work. It is all completely from India. I do more research in the US, but this work is completely in India. So the first innovation that I want to talk about is from a startup that I identified about 3 to 4 years back, which works on breast thermography. Now, traditionally for breast cancer screening, the gold standard for screening is a mammogram. So typically when a mammogram is done, even with a male or a female, it's an extremely dehumanizing process. What happens is just like how you would take a Xerox of your, if this paper has to be Xeroxed, you simply put it and then you cover it up and then you take a image of your sheet that you want to Xerox. In a mammogram is the same thing. They hold the breast tissue, put it across, and then then you take an image of the breast tissue. It's extremely dehumanizing. People have to derobe before the technician, whether it's a male or a female. Then you also have to have radiation. Now, mammograms or mammography is typically been a very Western and a very developed country approach. And this is something which truly does not work in India for two reasons. One, mammogram and mammography involves a high capex. And also the thing is you need technicians to be trained on that. And even more worse, the user experience isn't great. And then you have exposure to radiation. So around the world, people have been thinking about what could be those alternatives. And very interestingly, a PhD, a computer scientist from Indian Institute of Science, was working very closely with a radiologist in Bangalore because in the 1980s, FDA had approved a patent for thermography. So what it essentially means is you take a thermal image of the entire chest area in 5 different regions, convert every data point into a heat map, and then what we could do because of improvements in and the recent developments in AI and in deep learning is take this image, convert that, and come up with scores for the vasculature, for the alveolar tissue, as well as the general fat tissue in the breast, and come up with a score that is equivalent to a BIRAD score in a mammogram. Now, this is all the science that I shared, but essentially, this technology now, over the past 5 years, Neramai has about 50 patents around the world. It has about 10 patents from FDA. It has patents also from the European Agency. There's an entire science on how we've built this tool from a proof of concept till the stage of a population screening tool. And I'm very happy to inform you that in Punjab, we've been able to screen about 10,000 women in the last 6 months using this tool. What is even more gratifying is women are now coming in hordes to just get screened because the process is simple, that they go into a closed room where there is nobody except the thermal scanner, and the technician stays outside, and the thermal scanner takes a heat map of the chest area, and then the image is then transferred to the cloud by the technician, and then the deep learning algorithm converts this image into a BIRAD score, which then goes to our digital partner. Roche is a digital partner. And then we have a patient navigator who, what he does is, once the BIRAD score shows some abnormality, this patient navigator calls up the patient. And then we have a scheme called the Mukhyamantri Cancer Rahat Kosh, in which we provide free hospitalization to these people up to 3 lakh rupees. And we've empaneled a large number of hospitals in the state of Punjab, both in the private sector and the government sector. The patient navigator calls this patient and asks the choice of the patient. Would you want to go to the government sector? You want to go to the private sector? They ask for proximity, like where are you located? In your proximity, how many hospitals do you have? So we have an entire digital referral pathway, which is supported by Roche. And the navigator then helps this patient go, finds an appointment, fixes an appointment with an oncologist in these empaneled hospitals. And then once the confirmatory diagnosis happens, which is biopsy, then based on that, treatment options are provided to the patient, whether it is surgery or chemotherapy or radiotherapy. Essentially, we've screened about 10,000 women. Now, this is a very interesting innovation because it actually uses a biomedical device, which is a thermography equipment. It uses a deep learning algorithm, so it is AI augmented. It also uses a classic digital referral pathway. So This is nothing but a very interesting use of EMR. So it's all API based. And then this data goes into the system in the empanel hospitals. So through APIs, we've been able to feed into them. And at every stage, patient identifiers don't go outside the system. Now, the reason why I'm sharing this is there are islands of excellence in terms of digital innovation that are happening. We don't have massive innovations, but this is a very interesting innovation because for us to do an innovation where we take from the proof of concept stage till population screening level as a tool, in the US, probably I'll have to spend about 300 to maybe 30 to 300 million, especially for the scale that we wanted. But for Nirmai, we probably spend less than $2 million right from the proof of concept stage till the stage we are able to put it to the population screening. Now, this is just one innovation. There are 5 other similar innovations that we're doing in different areas. Now, the other one that I also want to talk to, this is about Nirmai. There is another interesting one. This is not so much about digital health, a very small component of digital health, but this is a very interesting program, what we call as the care companion model. Now, typically what happens in health in hospitals in India is every patient, when they go to the hospital, there are caregivers who go along with them, which are typically family members or their loved ones who accompany the patient. Now, the physicians, the providers in the healthcare system, don't really have the time to engage and educate these patients. And also, patients don't really have the time and they're anxious to understand. But these caregivers, these are important population who can be educated. So here is an organization, an NGO called Noora Health. It is based in Harvard. It's my Meta, where I did my MBA from. So what we did was I found a collaborator. His name is Saeed Alam. Saeed is a public health expert, is otherwise an internal medicine physician, but is very passionate about how do we truly involve caregivers and family members. So what we've started as a pilot about 4 years back, today it's now a national movement. There are about 18 states, and we've also just taken it to Bangladesh now. So what we're essentially doing is we use the time, it's a hospital-based pre-discharge education that nurses and paramedical staff give to the caregivers and the family members. So essentially, in the most simplistic way, what happens is that in an inpatient setting, if we have something like 20 patients in a medical ward, the nurse who has to administer the drugs to the patient, after administering the drug, takes a variety of digital tools to educate the patient, or more importantly, the caregiver. So she kind of groups patients who are all diabetic patients, she groups all COPD patients, and then what is common education that needs to be given to them, she gives group education to all these caregivers and essentially gives a tool for them so that they can be properly educated once they leave the hospital. Because essentially what happens is, as long as the patient is available in the hospital, there's adequate resources and adequate support. But what would happen to them once they leave the hospital? So essentially, this Noora Health comes in as a support. They kind of set it up in the hospital settings. But then once they leave the hospital, that's the time, again, there are enough resources available to the caregiver. Now, this is the second innovation that I wanted to talk about. There's a third one, which I will stop after the third, is more on how do we now, with India targeting elimination of tuberculosis, how do we truly ensure that TB is notified as a disease by the private providers? Now, we've been struggling with this problem for many years now, where what happens is a patient who is diagnosed with tuberculosis on the public sector side gets notified, you give them support, you give them diagnosis. But on the private sector side, private providers, although it's a notified thing, they wouldn't be able to respond because they have other challenges. And this is where very interesting innovations are happening in the country right now, where we now have these private partners. What they do is they have field officers, they have who basically go in and enroll all the private providers and ensure that every patient who gets diagnosed with tuberculosis is brought into the system. They are given incentives both to the patient and the provider, so that the incentives to the patient is they get free diagnosis, they get free treatment, and to the provider he gets an incentive for notifying in the national tuberculosis database. Now, this is again happening because of active participation by the private partners. Now, of course, there are a lot of variety of digital tools that are being used. So in short, what I essentially want to say is, without talking too much about the AI and machine learning applications where I specialize, even in very simple applications, there are a lot of digital health innovations that are happening in the States. There are small islands of excellence that are happening. Now, these were the 3 short examples I thought I'll share with you. Thank you.
Excellent. Excellent. I think this was actually mind blowing and amazing to see these innovations are happening in the government healthcare space where technology adoption till now has been uh, lagging, and there's a ray of hope that action has started, and like if innovations start happening in one state, they start spreading to the other state by the people get inspired and people start learning from each other. So let me move to our next speaker, Dr. Ismaeel from Saudi Arabia. And most of the audience is not aware about what all is happening in digital health insurance. So I will request you to please talk about what has been the journey, what has been the lessons, and what has been the impact of the digital journey, especially in the healthcare sector.
Okay. Thank you again, Doctor. Thank you for the audience as well. Yes, I think we are in the journey already. In our region, let's start with the governments. I'm talking about GCCs and generally Arab countries. It's not the Middle East. Firstly, they realize the importance of eHealth, the importance of technology, and how that could be the solution for the challenge at that time. Most of you, if you're not all, believe how the challenge it was. We are talking about medical errors, we are talking about the file capacities, we are talking about data sharing, all these consultations, rural areas, and all these challenges. Technology was the solution. When the governments believe on that, they put their strategies. For example, in Saudi Arabia, in 2004, it was created what's called the Saudi Association of Health Informatics. We're talking about around 20 years ago. That reflects how the government, it was realized the importance of technology since more than or around 2 decades. From that point, all these strategies and plan followed by plans, semi-plans, and all of that. And since then, up to date, we are talking about a huge investment in different ways. Investment in infrastructure, investment on devices, also investment in workforce. In Saudi Arabia, for example, today, there are plenty of academies, plenty of centers that are providing learning and teaching. Why? Because it's still up to now a challenge. The expert workforce in eHealth in general. From that point, we believe, the government believes in the importance of the participation or collaborating with the private sector. Governments alone, it's not enough. They should collaborate. They should complete it with the private sectors. When you talk about private sectors, you are talking about healthcare providers, also vendors, companies, international, national as well. And let's just, I'll just tell you something in terms of the huge investment. I'm not the one who said that. The Crown Prince, Mohammed bin Salman, in some interview, he said, we are gonna spend in the next 10 years more than what we have spent last 300 years. So that just to have an idea about what's going on. In Saudi Arabia example, we have the 2030 vision. As I mentioned a couple of minutes ago, Every citizen should have his EHR. Everyone should have his insurance card. You could choose from public or private hospital to get treatment. That could improve the quality, or it should improve the quality of healthcare and also reduce the cost for the government, the cost also for the private, for the citizens. When I have my card and I have the option to go anywhere I would like, for sure, you as a public healthcare provider and you as a private healthcare provider, you're trying, you'll do your best to attract me. Unless you provide me a high quality, cost effective services, I will not choose you. So we believe nowadays and also in the future, the investment in healthcare technology will be more and more. There are plenty of numbers. We are talking about billions of dollars gonna be spent and spent already, especially in my country, Saudi Arabia, in the Arab Emirates, Qatar, and plenty of countries. So we believe it's a challenge, but we believe how could we will get it, and how could we use this high technology with other partners to improve the healthcare provision in our country.
Fantastic. Thank you, Dr. Ismail. And I wish to have questions from the audience for the panelists. So if anyone wishes to ask, please raise your hand, identify your name, and you can speak. And if there are questions from audience are not there, I can of course ask. Anyone? Any doubts? Anything? None? So I will ask. So requesting Dr. Shafqat Khan that you have mentioned about so much like development is happening in the healthcare sector in your state, Jammu and Kashmir. How are you seeing the next 2 years or 3 years? Like how, what are the transformation you are in, like which is in the planning, which is being discussed, which is being visualized? So what is the future roadmap to talk about 3 years and role of IT or adoption of
The foremost challenge for hilly states is the terrain. And as you know, J&K is surrounded by the Himalayan mountainous terrain. We have hard and difficult to reach areas. In winters, some of the areas even get cut off. So, if suppose there's a digital initiative, how do we, look at the aspect of accessing that area? So we are trying to have fiber optics, to the line of wherever the connectivity is possible, or then Wi-Fi and other ways of getting a bandwidth to the areas. But we have decided recently in a meeting and instructed all hospitals, healthcare institutions to get high level of bandwidth, uninterrupted, seamless connectivity, and then make all hospitals Wi-Fi zones. So once we start a scan and share or scan and pull facility, we obviously need to give bandwidth to internet connectivity to the patient also. If he needs to download an ABHA app or say an application, private application, Briefcase, Bajaj, Aragase to any other developer. There are so many developers coming with their own softwares these days, and we appreciate that, in fact, and we are promoting those softwares also. So we say that we will allow anybody to have access to the Wi-Fi in the hospital to create an ease of accessing my digital network. Number two, as Dr. Ismail was saying, that it is very important to judge the stakeholders' comfort in whatever system you are using. That is a patient, for example, is he good with coming with a smartphone and downloading a software and then scanning your QR code of the hospital and getting registered, getting a token generated? We are now devising that we give him him an ABA card with a QR code, the person, rather than giving him a smartphone, and scan and pull his information from his card, rather than asking him to get a smartphone. So that's a very viable option. There are small, small options which will, we have to get in the shoes of the patient, the citizen, because people like you and me generally have access to healthcare uh, through direct contact. A bureaucrat has his own access, a technocrat has his own access, and this also calls somebody gets a appointment at high level. But it is the common Indian, common mass, a common person whose perspective has to be looked at when he accesses a healthcare facility. When he is, in the line, standing in the sun. Most of our government hospitals, unfortunately, till today, have OPD registration ticket kiosks outside the hospital, not inside. That you call them inside like a bank operates, and then make them sit and then generate the token. They are generating the token outside in the sun or snow. Trust me, I've seen this in some of the hospitals where it is snowing outside. The temperature is -6 degrees, and the patient is standing in a queue for a registration slip. It's the truth. It's a very bitter truth. But we have to accept it. And then solutions are that we have to re-engineer our facilities, re-engineer from the need of the patient. And then not only the patient, but the healthcare providers, the policy makers also have to be very, at ease. A doctor who is supposed to see 20, 30, 50 patients is seeing 200 patients for a day, which is unjust. We have to, that is where the digital technologies, their presence is very important. The digital technology will enable to register a patient at the OPD site, register him to the doctor of where he wants to go, the orthopedician, the pediatrician, or whoever, and then create a slot for him for 10 minutes. And the 10-minute or 15-minute slot, the doctor has to see the patient for those 15 minutes and then call the next patient in on the next slot so that the patient doesn't feel cheated and the doctor also doesn't feel overburdened. So I think digital technologies will enable us to rationalize the delivery of healthcare, to to create a space for everybody, a very comfort. When we talk about smart cities, people think digital is smart, but digital is not smart all the time. To put digital into a very rational manner, a little bit of digital, a little bit of traditional, a little bit of, heart into things. So that is to make the cities, the facilities we give, and create a happy citizen, happiness. What should a smart city give? What should a digital, initiative give? It should give happiness, ease to the patient. So I understand that we in J&K are striving very hard, more than ever. And trust me, when I say more than ever, it is true that healthcare stands reformed in J&K. So much so that in the public health sector, we have great doctors we are producing, very quality doctors. We have stopped infrastructure projects. We say we don't want to make new buildings. We have had enough. Our politicians have made, buildings left, right, and center in J&K. Now we want to rationalize those buildings. We have a remote sensing ecology department. We did a survey. We said that we will give extra buildings to different departments. We don't need them. We will have a hospital where there are, particular area, particular village where it is accessible. In Doda district is a very far off district in J&K. You must be knowing. There, the population is on one side of the river. The hospital is on the other side of the river because the good man politician wanted it to be the way that way in the previous, systems. We said, no way. We will give that building to the revenue department. We will have an hospital which is already there, which was old, which we'll refurbish and have. So, re-engineering healthcare has been our top priority, and re-engineering at every step, not only the infrastructure, but the flows, the patient and doctor, the workflow charts and the responsibilities and the roles assigned to each of us. The healthcare worker, ASHA worker of this country, entire country, has been a game changer. ASHA is delivering everything these days, from making Abha cards to immunizing people to arranging prenatal, postnatal checkups of women. I think the healthcare of this country is uh, ever changing, and I assure you, I have been in many workshops across the country. Uh, Healthcare is getting a boost in a big way. The spending, maybe some people say, is less uh, from the budgetary part of part of it, but I think it is being rationally spent now. It is being not politically spent. It is being spent in a very wise manner, and I expect governments to work on their finances, on their financial budgets of the health in a very rational manner, and appropriate money to smart systems, smart digitization, making AI-based machine learning processes good, because healthcare is going to change. Must have seen the Google Heads video recently saying that now by looking at the retina, we will predict diseases. Just the retinal, observations will tell you how the trend of disease will in the future. So I think uh, you all sitting here are into innovative processes and uh, healthcare initiatives. I wish all of you good luck and best of all. Thank you very much.
Thank you, Ravi, Shafqat. Excellent remarks. Very, very encouraging. You talked about re-engineering healthcare, and you talked about patient-centric approach. So, taking those keywords, actually, I will request Dr. Taking those two things here, I will request Dr. Karthik to talk about two words, that's re-engineering healthcare and patient-centric approach in the government healthcare system in India. Your views.
So I think in terms of re-engineering healthcare, it's been widely talked about, but because it's too broad, I'll stay with just one basic element and one basic thought, which is still making only which is not made complete headway in India, but it's a big movement in the West. I think Dr. Ismaeel talked about it as well. When we're talking about patient-centered approach or patient engagement, what is extremely important is to actually make a hospital safe. Today, the biggest problem that we have in our country is we are oblivious of the fact that doctors are prone to do mistakes. Doctors will commit errors. This is something that we've not accepted as a society. So, what do we do to doctors? We beat doctors. We believe that doctors are negligent. We believe that doctors are here only to mint money. There will be black sheep. But the fact is, in the US, patient errors, medical errors, are the third commonest cause of death in the US. This is because the US as a society has recognized and has acknowledged that doctors are human beings, and even after 12 years of solid medical education, a doctor is prone to do mistakes. So, therefore, what happens in a healthcare system in the US is doctors report errors voluntarily. So the system encourages them to report errors. Some errors reach patient, cause harm to the patient. Some errors don't reach the patient. They are called near misses. And in a typical hospital, in leading big hospitals in the US, these near misses are called good catches. So you celebrate the fact that here is an error that I committed, it did not reach the patient, but you then use these errors to educate everybody around. And then there's also a recognition by the system that if a doctor does a mistake, it is a human error. You go on to understand how can we have a system that will ensure that these errors don't happen in the future. Now, over the past 25, 30 years in the US, there is an entire law, a federal law, that ensures all healthcare systems to report out errors that have caused harm to the patient. Now, these errors that cause harm to the patient, which are adverse effects or sentinel events, are then at a national level examined, understood, studied, and then you find out reasons why in different specialties these errors are happening. and then you try and improve that. Now, for example, in the field where I specialize, radiation oncology, there are about one mistake that happens in out of 10,000 patients who go undergo radiation therapy in the US. Now, radiation, unfortunately, can neither be felt, nor seen, nor heard. So a patient simply lies on the bed and he cannot hear it, he can't smell it, he can't feel it, and radiation is given. Now, imagine in that patient, if there is a small mistake in the radiation plan, the, the damage that is caused to the patient is humongous. Now, the problem in a country like ours is we have not even recognized what is patient safety. So therefore, what happens is when our doctors do mistakes, we believe that this doctor has purposely done mistake to our patients, to our families. So we get emotional about it and we beat the doctor. And there is medical negligence, of course. We need to separate the two of them. One is medical negligence, willful negligence, and other is human errors. Now, the science of understanding human errors, essentially, if you think about something like aviation, for example, as on today, I will be probably more comfortable sending my child in a aircraft all alone rather than sending my child to a hospital in India. This is primarily because in India, I'm not even aware, not only India for that matter, even in Harvard or even in the Yale hospital that I work. The problem is our hospitals around the world, mistakes happen, errors happen. But can we use these errors to learn from them? Can we help our medical physicians to learn? So essentially what I'm trying to say is before we go for a patient-centered approach, before we talk about making patients engaged into the healthcare system, which is of course very important, we first have to make our healthcare system safer for patients. Patients who are vulnerable, patients who are extremely, where there's a huge power differential between a physician and a patient, it is important to first make hospitals safer before we actually talk about patient education, patient engagement, or a patient-centered approach. And I think that is what, as a country, as a society, we still have to unravel. And I think patient safety as a movement still needs to come to our country. And we are making small progress, but not a lot. So I know the time is up. So I just wanted to kind of put that out there as a conversation for us as a society. And of course, this is conversation that we're having in the government. Of course, the academia and the industry and non-profits have to come together to kind of talk about the need to make our hospitals safe. And for that, we need to encourage our providers to report errors that happen in hospitals. And we as a society should need to understand that these doctors, with despite all their training, are prone to commit errors, and it should be okay. So just wanted to share those thoughts. Thank you.
Excellent inputs, Dr. Karthik. Thank you so much. Very nice. And yeah, so
I am Dr. K.K. Jain, medical student from one of the hospital in Chandni Chowk. I want to know what is the accuracy of this breast thermography in comparison with the routine mammography, and is it available in Delhi or not?
What's the second question?
Is it this breast thermography is available in Delhi,
Okay,
in our city?
That's a great question. So I don't want to speak for Niramai. I'll be speaking about this more as a scientist and not as not as somebody representing the department. Purely in terms of science, typically when AI and machine learning applications are built, today, Dr. Khan also talked about the Google AI machine learning application. Now, today, AI and machine learning, everybody would talk about the beautiful things about AI and machine learning. But what I want to talk about, when I talk about AI and machine learning, I want to do it with a lot of responsibility. Because I think AI and machine learning, one needs to think about AI and machine learning just like how we think about a drug. When we take a drug, what we do is it goes through different 5 phases of development. It's not that somebody innovates, identifies a drug, and we start taking it. So when a drug gets into the system, wherein it gets regulated, there is both safety check as well as an efficacious check. So there are 5 phases of drug development. Initially, there will be animal trials and there'll be clinical trials for both safety and efficacy, which is typically the way vaccines get developed as well. Essentially, we as AI and machine learning experts also talk about not just AI and machine learning applications being built and thrown to the world and using people as guinea pigs. We are responsible AI machine learning experts, which basically means we're interested in the science of it. So when any AI and machine learning application is built, typically what happens is there's a proof of concept. Initially, models are built. And after that, the models get optimized. So what we do is we want the data sets to be very diverse. We want to ensure that this data set truly reflects the population. And then as a medical superintendent asked here, we also look into comparing this tool with existing standards. So for example, with Nirmai, what we did was we started off first with testing it on positive patients so that the machine learning algorithm can actually learn what is abnormality and what is normality. And then what we started doing was comparing symptomatic versus asymptomatic patients. We also compared dense breasts versus non-dense breasts. So using a variety of experiments. So before it became a population level screening tool, we've done this study for about 5 years across 15 different studies that have been done. So we've done it as single pilot, we've done multi-center studies, we've done multi-institutional studies. So before, in terms of accuracy, to just answer the question, yes, in terms of sensitivity, it is very good. It is much better than a mammogram in terms of detecting abnormality in both symptomatic, asymptomatic. It is also better in terms of detecting the abnormality in a dense breast tissue. Its accuracy is much higher. But it is not just accuracy alone that we look in any AI and machine learning. We also look for high specificity as well. In terms of specificity, Nirmai matches mammogram, but we also did not compare Nirmai's tool with just mammogram alone. We also compared with mammogram plus ultrasound, because typically both of them can be done for any breast cancer screening. So essentially, to just summarize, this tool that is being now used in Punjab, it has undergone 11 to 12 iterations in terms of algorithmic development. There are about 15 studies that have been done. So if you look for neramai.com and you look into the technology page, all these studies have been published in peer-reviewed top journals in the world. And now when we're using it as a screening tool, we are confident that this tool is extremely efficacious, it is safe, and is also highly accurate in comparison, not just with mammogram, but also mammogram and ultrasound as a combination. Now, trying to answer this next question, is it available in Delhi? It is a patented product. So anyone who wants to buy this product have to apply. So for example, in Punjab, using NHM funds, we use this as an innovative project. We have an MOU that we signed with Nirmai. It is not a very expensive tool. It is about 6.5 to 7 lakh rupees is the cost of the thermal scanner. But it is not just a tool alone that you need to, because it's a patented product and it's a fairly new company. So I'm not getting into the financials. But I think as far as I understand, in Delhi, it's not available. But if you reach out to Nirmai might be interested. And there are other, I've had conversations with Delhi Health Secretary as well. Other states like Uttarakhand, Orissa, UP, they've all been interested. But they're all waiting for results from Punjab. I think by July end, we are hoping to publish our study in Lancet. And then probably we will look at scaling this up at the national level as well. In the national level, MD NHM at the national level also has been interested in doing this study. But we want to do it in a very scientific method. So after having done the initial studies in the southern part of India, we've now done it at a population level in Punjab. But we are hoping to then scale it up to other states over the next few months or year, rather than just being excited about a product and then rolling it in all parts of the country, if I can say so. Does that help? Yeah, thank you. Thank you. Great question.
Thank you.